Chase.
Hi, can you hear me okay?
I can, yes.
Okay. Okay, I think everything's good.
Yeah, if you can try your screen share. Let's
Yes.
see. Oops, hold on. Try it now.
Okay. Uh, okay. I think it looks like it's working. I don't have the PowerPoint pulled up, but
So I see your full screen, yes.
okay. Alrighty. Well, I'll get it pulled up, but I think it should work okay.
Okay, just making sure.
Thank you.
You're welcome. So we'll start with our case and then we'll go on to the didactic.
Perfect.
All right. And just so you know, I will spotlight you when it's time for you to talk, and that's just so
Okay.
that no one else can interrupt and do anything
Gotcha.
awkward during these.
Okay.
So
Great.
sometimes that throws people a little off a little bit. So just letting you know so that you're not like thrown off, like, whoa.
Okay. Great. Thanks.
You're- Hi, Dr. Peckmabian.
Hello, how are you doing?
I'm good. How are you?
Doing well. You nice and warm up there, or you nice and cold up there?
I'm nice and warm. I'm nice and warm. Yeah, I'm
Okay,
good. I was kind of a little cold last week, but I'm good now.
good deal, good deal.
How was your birthday?
It was very nice, very nice. Thoroughly enjoyed it. Took off the whole week, so it's a nice.
Okay.
Yeah.
Good, good, good. I know you, I think you're similar to me where your year starts after your birthday since it's so early in the year. So
Absolutely.
I understand that completely.
Take care.
We'll be getting started in just a couple minutes. So Dr. Cantor is joining now, so I'll go ahead and get started with our opening slides, just so that we can be respectful of everyone's time.
All right.
All right, so welcome today to our ECHO. We have our accreditation and EOE statements. We do not have any disclosures from our presenter today. And then you can scan the QR code, and I'll put a link in the chat box for the CME information.
And if anybody needs any CME on what happens when a stress ball explodes all over your office, you guys just let me know.
And also want to make sure that everyone's aware to share with your APPs about our upcoming APP support ECHO sessions. And we got a QR code there where you can scan to register, but just wanted to share some of the topics that are upcoming. These are hosted on Thursdays by Johns Hopkins and then on select Tuesdays by UAB. So we want to make sure that people are aware. Thursdays, the third Thursday at 11 a.m. and the first Tuesday at 8 a.m. Central Time.
We definitely want to encourage all the APPs are welcome. Physicians, sorry, you're not really welcome, actually. It really is supposed to be safe time for our nurse practitioners and physician assistants. All right, I think we're going to have our case first today, and that is going to be, I believe, presenting is Dr. Mari from USA. Dr. Mari, are you here?
Don't see her name here.
Anybody? Dr. Mari, are you here? Going once, going twice. Okay, maybe she got called in with a patient. Instead, we will go straight to our didactic today. And then if she's able to join, we can, of course, bring back our case in a little while. Chase Beeman is going to be speaking to us today, a pediatric hematologist, oncologist, genetic counselor at Norton Children's Hospital in Louisville. She received her graduate degree from Ohio State, and she sees patients throughout heme and onc, including participating in multidisciplinary care for individuals with sickle cell disease. She's had a lot of experience in research, and I'm just really excited for her to talk about the utilization of genetic counseling and genetic testing for people with sickle cell disease today.
Thank you so much for that intro. I will go ahead and get my slides pulled up and shared here. Give me just one moment. Okay. Can everybody see my screen okay and hear me okay?
There, well, we're getting there. Your screen's a little funny, but it's getting there.
Is it getting there?
Yeah, it had some weird rectangles in it, but I think you're going to be good.
Okay, great. Thank you. Thank you so much for having me. I'm really looking forward to talking a little bit about genetic counseling and genetic testing for patients with sickle cell disease and how both may be used in a clinical setting really throughout the lifetime of a patient with sickle cell. I think we're all aware that care for sickle cell patients is really a multidisciplinary process, and comprehensive and holistic care for patients with sickle cell disease can truly promote improved quality of life. It can reduce hospital admissions, reduce disease-related morbidity, and increase agency that our patients have in their own care. And a multidisciplinary care team for sickle cell disease is really wide and diverse. And today I'll really be focusing specifically on the role a genetic counselor might play within that team. For anybody who may be unfamiliar with genetic counselors and what their role and scope may be, I wanted to start out by just describing the role. Genetic counseling as a whole is the process of helping people understand and adapt to medical, psychological, and familial implications of the genetic contributions of a disease. But genetic counselors specifically are health professionals who interpret family histories and medical histories to help assess for the chance of a disease occurring. They can also provide education about inheritance, genetic testing options, management, prevention, resources, and connect families to research, and also use counseling to promote informed choices and help families adapt to a condition that may be within their family. And genetic counseling for sickle cell disease can really occur throughout a patient's lifetime. And I certainly touch base with patients throughout various time points in their life, which is a really wonderful opportunity to help educate them and support them as their care may change over time. And I'll kind of walk through each phase and how genetic counseling may fit into that for our patients. So the first touch point is typically with newborns who are newly diagnosed with sickle cell disease. And just as a quick broad overview, genetic counseling at this stage is really just to provide information about a sickle cell diagnosis and what the disease is for families who may not know much about it. We can also really help to support the adjustment to a new diagnosis. Families may experience particular psychological or psychosocial concerns relating to this, and this being a genetic condition, things such as guilt that this was passed down, or how did this happen, or did they do something wrong? And genetic counselors are really well equipped to have those conversations with families. We also will provide inheritance counseling at this point in time. For some families, they weren't aware that they had a chance of having a child with sickle cell disease. And so helping them understand this and what that chance may look like in the future can be beneficial for some families. And there may be cases where genetic testing is helpful and necessary for moving along a diagnosis. And so we may support that effort as well. And so I want to segue into this a little bit because I think that this is a growing area. And really this question is, when is genetic testing actually indicated for sickle cell disease? And to sort of start off with basics just of newborn screening itself, this is a screen that uses HPLC or IEF to detect hemoglobinopathies. And a little historical background, this has been here for quite a while. It was initiated in 1975, and New York was the first state to utilize this. But now it's mandated in all 50 states. And although it is a screening test, it is really high sensitivity and specificity. It's important to note this may be compromised in infants who have had a blood transfusion or in infants who are very premature. But it is overall a good test for detecting sickle cell disease. It does, however, require confirmatory testing. And there are some challenges with newborn screening, particularly trying to confirm results. We know that there can be variable interpretation of newborn screening results. So for example, a child whose newborn screen comes back as FS, this could be hemoglobin SS or hemoglobin S beta 0 thalassemia. An FSA could be hemoglobin S beta plus, or it could be hemoglobin AS or sickle cell trait. And sometimes we may also get odd results on newborn screening. And I share this one that actually came through our institution. That was FEA and S. And so these results can sometimes need a little extra support to help work them out. There can also be challenges with age-related delays for a diagnosis with getting a hemoglobin electrophoresis on infants, and also trying to identify if there are any potential disease-modifying factors, such as hereditary persistence of fetal hemoglobin. And genetic testing can support some of these situations. So it can help clarify uncertain results, especially if you have something sort of odd or unfamiliar and it feels like genetic testing may clarify what exactly is going on. It can close the gap for age-related delays. There's no delay necessary to have genetic testing done. We can do it right at birth if we wanted to. And it's also comprehensive, and so it can help us identify children who may have a disease-modifying factor, such as hereditary persistence of fetal hemoglobin. And I'll just use this quick example of the utility of genetic testing in a case where we could see somebody who has FS and had 88% F and 12% S on their follow-up electrophoresis. And if we do alpha and beta globin sequencing for this case, we would learn that this child had hemoglobin S and hereditary persistence of fetal hemoglobin. And that would change our outcomes in the way that we manage for the management team, that we don't need hydroxyurea, penicillin, or other treatments. And we can also counsel this family on the generally benign nature that we would expect for this child. And genetic counseling can also be used in the newborn stage for sickle cell trait. And I want to touch on this too, because I think it's an overlooked but still important area. Genetic counseling for sickle cell trait is sometimes done by genetic counselors and sometimes done by pediatricians, and in other cases done by state health departments. But this is just a very important time to help educate families on the differences between sickle cell trait and sickle cell disease. There can certainly be misconceptions from families about what those differences are, if sickle cell trait will develop into sickle cell disease, or how they inherited this, or how they developed this trait. We can also help discuss the generally benign nature of sickle cell trait, but some families do have concerns and questions about health problems that they may have heard about, or risks for renal cancer, and those are conversations I've had with families before. Of course, explaining inheritance patterns and helping to facilitate parental testing or provide referrals to places that can do testing for parents so that they can better understand the future chances for having a child with sickle cell disease. And so now we can kind of transition into our next phase that genetic counseling might be used, which is for our adolescents and our young adults who are then transitioning into adult care. Our adolescent and transition adult care kind of phase for genetic counseling tends to look sort of similar. And at least for me and the patients that I see, it's sort of an evolving conversation that happens over time. Oftentimes, these conversations will look like talking about what causes sickle cell disease and the relationship between sickle cell disease and the symptoms that they have. So we'll use that visual that I included down. That's a common one I use with our younger kids, looking at the shapes of red blood cells and comparing them to a donut versus a banana, and how our donut versus banana shapes can lead to them having the symptoms that they have. As children get older, we may discuss their particular genotype or the different types of hemoglobinopathies that they may have. And especially as they're getting into a young adult, sort of adult transition phase, discussing inheritance and reproductive counseling so that they feel kind of equipped and prepared with knowledge to move forward as an adult with their care. And we'll use visual aids such as this one. They're looking at what the chance would be to have a child with sickle cell disease if they have sickle cell and their partner has trait. We know from research that adolescents with sickle cell disease are interested in genetic counseling and also have interest in learning about inheritance or have questions about it. And we see that approximately half of young adults who are transitioning to adult care report that they need more genetic counseling. And so there's certainly a need for genetic counseling services to fit in these adolescent and young adult years. And so now our patients move on into adulthood, and maybe some of them want to start families of their own. And genetic counseling is certainly very integrated and impactful for prenatal timeframes. This is sort of just a general summary of prenatal genetic testing as a whole for sickle cell. And overall, genetic carrier screening should be offered to all pregnant women. It really, ideally, in a perfect world, would be offered before somebody was pregnant, but oftentimes it's offered during early stages of the pregnancy. And screening for hemoglobinopathy traits should be offered universally to patients, not based off of ethnicities. And this can be done through a complete blood count and hemoglobin electrophoresis, or other places may choose to do gene sequencing, looking at HbA1 and 2 and HBB. Gene sequencing is more comprehensive for catching individuals who might be silent carriers of alpha thalassemia. Just as a note for kind of the differences between the two. And follow-up testing for partners should be offered based on these results to help families make decisions and understand the potential future outcomes. And for partners of individuals who have known sickle cell disease, we should be offering carrier screening to them as an option. And prenatal genetic counseling during this phase can be really varied and oftentimes quite a lot of information for families. But for families who have an increased chance of having a child with sickle cell disease, we typically, during a genetic counseling conversation, will discuss diagnostic testing options for them and explore kind of the limitations and benefits of each option and which one fits in with their personal healthcare goals. We will use this time to discuss features and treatments for sickle cell disease. We will discuss inheritance and reproductive risks for families, as well as discuss any screening and diagnostic options. Some screening options and diagnostic options that are commonly discussed are things such as maternal cell-free DNA. This is sort of an interesting and maybe a little bit of a newer option for screening for fetal sickle cell disease. And this uses maternal serum to detect if the fetus potentially could have sickle cell disease. This is something that's typically used more for people who have sickle cell trait, though not for our patients affected with sickle cell disease. But we can also offer families an option such as a chorionic villus sampling or amniocentesis if they would like to know during the pregnancy if a fetus is affected. We can do testing on cord blood after a baby is born, or we can just wait and see what newborn screening says as well. And the options for this are all given so that a patient can engage in a balanced discussion and a neutral discussion about all of their various pregnancy options available to them. This may look like discussing termination, adoption, continuation of pregnancy with medical expectations once baby is born. It's really up to the family and directed by them and what they look for in their care and what they look for in their reproductive options. And genetic counseling during pre-pregnancy for our patients can also include a discussion of IVF and PGT. And this is a big area that we'll have a discussion about as well for those that are interested in it. To touch and expand on pre-implantation genetic testing for sickle cell disease more, PGT is a process that uses in vitro fertilization for genetic testing of embryos prior to their implantation. This is a process that allows families to select embryos that are unaffected by sickle cell disease. It could also be used to select embryos that could be a potential stem cell donor for an existing child. We can look at studies that looked at parental interests in PGT for sickle cell disease. And we really do see that parents of children with sickle cell disease demonstrate an interest in having this information. In this particular study, about 3/4 of parents lacked awareness of PGT as an option for sickle cell disease. But when they learned about it, they then reported that they viewed learning about PGT as important. Most of them said that they would consider using PGT for future pregnancy planning. And most of them also thought that it should be discussed at the first hematology appointment with a newborn. There are, of course, challenges to pre-implantation genetic testing. And when I have these conversations with patients, I always try to touch on both the benefits and the positives, but also that there can be some challenges that may need to be considered. It's certainly a very cost prohibitive option. The average cost is oftentimes quoted around $30,000, and it's variable what insurance will cover, if they will cover things. Although there is some interesting research to suggest that PGT may be generally more cost effective than the cost of care for a lifetime for a patient with sickle cell disease. And perhaps that's some evidence that insurance companies may potentially want to offer better coverage for this, although we can never tell what the future will say for that. There are also ethical considerations that parents and families may have and may want to discuss before they make any decisions. And then there's, of course, also the burden of fertility treatments and just extra medical care on patients. And then genetic counseling sort of in the last section can really be used to help families who are thinking about treatments or just general health management. We now have so many gene therapies coming onto the market, like Lyfgenia, Casgevy, and Zynteglo for beta thalassemia. And genetic counselors can be really useful in educating on gene therapy, especially for families that have lots of questions about how it works. How is this kind of editing somebody's genetics? What does it mean for them and their future? And also discussing reproductive risks with families. We know that even though somebody is undergoing gene therapy, they still have a chance of having children with sickle cell disease in the future. Gene therapy doesn't change that. And that might be a misconception that some families have if they undergo gene therapy or if they undergo a stem cell transplant. And that sort of leads me to my next area, which is for stem cell transplants. Again, genetic counselors can be helpful in discussing reproductive risks, but also helping to evaluate donor relatives if we have concerning family histories for other genetic conditions that may make us pause in terms of transplanting. And then genetic counselors can be really useful in identifying other genetic conditions within a family. And this is one that I tend to come across relatively frequently in a clinical setting, just kind of through a holistic lens in doing a complete family history when I meet with families. We will sort of do a family and medical risk assessment for other health conditions. And sometimes we may unearth concern for cardiac conditions or cancer in the family that could prompt further genetic counseling, genetic testing. And if we do learn of other conditions in the family, it may change recommendations for our patients' preventative screening. And ideally, all of this is with the goal of supporting our patients and helping them live longer and happier lives through preventative care. And so that's sort of walking us through the different ways that genetic counseling and genetic testing may be used in the lifespan of a patient with sickle cell disease. And kind of to summarize it all, really the goal is to support prenatal preparedness and decision-making, help our families facilitate quicker and more accurate diagnoses for their children. It helps us engage children and young adults in understanding their condition and having autonomy in their care, and prepares our adult patients for making more informed healthcare decisions and just understanding their condition better. And that is all that I wanted to speak on today. And if anybody has questions or comments, I'm happy to take them.
And that was fantastic and incredibly comprehensive. So much appreciated. I have one question, which is, does Medicaid tend to cover it in your area? Do they cover genetic counseling?
Yeah, so Medicaid does cover genetic counseling services, which is great. Usually it covers genetic testing as well within our institution. So I don't typically expect patients to get a bill for genetic testing. I'm sure it potentially could vary at other, states and institutions, but we've definitely been fortunate here to be able to get that covered when needed.
Awesome, thank you.
Mm-hmm.
Other questions? Sorry, if you have your hand up, I can't. So one of our colleagues says, I'm a genetic counselor in a general genetics group as well as the sickle cell clinic. One major overlap has been developmental delay. The question I come up with is when to consider developmental delay as part of sickle cell disease or when I should evaluate it on its own.
Yeah, I definitely do have patients who come through who maybe have a more complex picture. Usually, at least how I've approached them is when I have kind of specific concerns for things that may be more likely to be genetic. So, thinking like autism, and our standard of care would be to offer them a microarray and Fragile X. And then maybe that's a case where I would want to dig a little deeper. Or if their developmental delay seemed particularly severe and persistent, and there wasn't another explanation for it. Maybe if I had a patient who had a stroke at a young age, and that might explain why they have some delays, I would be less concerned. But if it was a child where I couldn't really see another explanation, or we had some clear guideline for testing, then I would definitely want to look further at it, I think, and try to find some other answers.
And I will just, for other people to note, the National Alliance has a neurocognitive neuropsych working group who has come up with some really excellent developmental screening recommendations that'll go through final vote in the next 2 weeks. And so I think hopefully that will help narrow down who needs some of those additional assessments, because it's certainly not my forte, but that was really a great question.
Yeah, I'll add as well that if you have psychologists at your institution, they tend to be super wonderful at kind of helping tease out and differentiate what potentially could be causes. And so working with them is probably very helpful. I've certainly leaned on ours a lot.
And do you work within the sickle cell clinic? Like, do you come there, or do you have people come to you?
I work within our sickle cell clinic. So I attend whenever patients are there, and sort of just pick out who needs to be seen and work from there. Mm-hmm.
Awesome. Any other questions? All right, well, thank you. That was a great presentation. I really enjoyed that and certainly learned a lot. Something I don't think we talk enough about is how to involve genetic screening in our sickle cell centers. So I really think that was fantastic.
Thank you.
All right, moving along to our case today. I see Dr. Marie has joined us. Dr. Marie, I lost your title of your case, so I'm just going to let you go to it.
Right. Okay. So can you all hear me? Good afternoon.
We can.
Okay. And can you all see the screen as well?
Yeah, if you want, you can put it in presentation mode, or you can leave it as it is.
Yes. Okay. Awesome. So I'm Preeti Mari, one of the pediatric hematologists at USA Health in Mobile, Alabama. So I have a simple case presentation today, or a single case presentation today. I have no disclosures. And so proceeding with the case, we have a 12-year-old female with known hemoglobin SS genotype with complicated disease scores. So few of the following slides will highlight the complications as such. She was born via C-section for repeat at 37 weeks. Maternal HIV was, she was positive for that, but it was well controlled with antiviral therapy during the pregnancy. And the newborn course was otherwise uncomplicated, and she continued to have routine HIV DNA PCRs being negative. So from that standpoint, she had no ongoing infectious concerns. And newborn screen came back positive for FS, and she has since been plugged with our sickle cell disease comprehensive clinic here at USA Health. For the first few months, she has been doing well and has been started on routine medications, including PenVK and folic acid. And she seems to be growing well, meeting developmental milestones. But she, when she turned 6 months, about 6 months, is when her first pain crisis happened, presented as dactylitis, and was managed outpatient, but then eventually required to be hospitalized for her for opioid use. And a couple of months later, she was diagnosed with bacterial pneumonia, and she was hospitalized at that point as well. And since then, and between the first and second year of life, she's had multiple hospitalizations, up to 5. And after that, she was continuing to present to us and also to the local ED for minor to major pain crisis. And those pain crises eventually evolved to be a complicated pain crisis with prolonged hospital stays with or without fever, and a few acute chest syndrome episodes starting at the age of 3. And all along, family has been very compliant with the routine care, including hydroxyurea initiation and optimization as and when possible based on her blood counts. And during the investigation, she was noted to have asymmetrical kidneys, right smaller than the left, with some left hydroerythronephrosis without any obstructive uropathy. Nephrology has been following. She never had any ongoing issues with UTIs or acute kidney injury. And during her first few years, she did have issues with weight gain, but eventually she caught on later. And then constipation, moderate to major constipation, where she needed bowel clean out regimens very frequently. Spleen was noticed to be enlarged, but then she never was deemed to have splenic sequestration as such, and had recurrent tonsillitis and pharyngitis, which resulted in tonsillectomy and adenoidectomy. It was uncomplicated surgery. But then the multiple hospitalization saga continued, with missed days at school was beginning to affect her psyche as she was growing older, and she was seeing frequent course of antibiotics and IV opioids. As expected. So at about age 5 and upwards, her clinical course got worse with, again, multiple acute chest syndrome, where she was getting admitted with at least 3 episodes per year, and then minor pain crises that were managed at home in the interim. And she was also having a lot of back pain, to the point it resulted in chronic back pain, and recurrent MRIs has revealed multiple vertebral body bone infarctions. And at some point, she also had a clinical presentation of lumbar osteomyelitis, for which she was adequately treated, and was noted to have avascular necrosis of right femur. And then as she aged to up to 8, she was noted to have an unprovoked DVT on her left side, which was progressively worsening to include her iliac and abdominal vessels as well. And at the same point, she had an unprovoked PE during the same admission. And further investigations revealed that she had a duplicated IVC, which was later deemed to be a normal variant, but that was also setting her up for more thrombotic events. And after 6 months of initial DVT treatment, when the treatment was stopped, she proved to have a recurrent DVT within 1 to 2 weeks of discontinuing. So her protein C and S along the way were somewhat measured to be low, but it was unclear if it was a clot-related consumption issue. Then there was a family history that we realized that mom and mom's sister also have low protein C, where she was placed on long-term anticoagulation by her own hematologist. But because of the unprovoked DVT episodes, which are significant, and the anatomical variant that she's had, with the chronic persistent clot, even though non-occlusive, we put her on long-term anticoagulation with an oral DOAC. She had some of the minor issues associated with her clinical course was moderate persistent asthma, vitamin D deficiency, and allergic rhinitis. At one point, when she came into the hospital with the asthma exacerbation, she went into respiratory failure, required mechanical ventilation. That was at the age of 9, continued to have the chronic DVT issues. And that same year, she was seen to have a right femur abscess, which required incision and drainage, and that added to the hospital course. Then the year after year, she continued to have at least 3 episodes of acute chest in a year. So the only saving grace was her TCDs have been normal. She did not have any overt clinical signs or symptoms of stroke, and renal function has been good all along. Owing to her chronic pain and multiple frequent complications, she was started on exchange transfusions, more so to help with pain symptoms. That was about the age of 10. Along the course, we were contemplating transplant evaluation as well, and she's from Mississippi, so she was seen and evaluated parallelly while we were planning to start the exchange transfusions for chronic pain. Chronic pain was well managed, I must say, with exchange transfusions, because her hospitalizations have significantly improved and gone down with that. But as we all are aware, there is always an alloimmunization concern, and she did have a low-level alloimmunization, which limited the availability of units from time to time for exchange. Again, continues to be compliant with HU, and at this point, she was on maximal dose of HU, 35 milligrams per kilo, without any dose-limiting toxicities. Transplant evaluation has returned to having no matched donors. She does not have any biological siblings. And at that point, we referred her to Nashville for gene therapy clinical trial evaluation. And she was about 10 and a half years age at that time. For her, the prerequisites that we were looking at closely based on the Center for Gene Therapy was that she did not have an acute infection at that time. Then there was no donor availability for transplant. And hemoglobin S had to be about less than 30%, or we were going to work on getting it there. But most importantly, she definitely had more than 2 pain crises per year with hospital admissions. Now, to proceed with the clinical course, she was evaluated for the Vertex-sponsored clinical trial, CTX001, which was a gene editing trial using CRISPR technique. And she was seen face-to-face with a prolonged visit to discuss, what are the implications going into gene therapy, consented in June 2023. And in the interim, if we continue with exchange transfusions every 3 to 4 weeks to keep the hemoglobin S requirement per the team in Nashville to less than 30%. It was mostly possible, but we also had issues with, donor unit availability because of our allo immunization. And eventually, her stem cells were collected in October 2023 with a mobilizing agent. And then she came back to us and continued with the exchange transfusions. And all along, since we started the exchange transfusions, she has not had major pain crisis. There was one event where it was a moderate pain crisis around the time of a surgical procedure, which was managed in the hospital, but nothing compared to her prior significant episodes. The trial also offered to provide for fertility preservation, and she underwent successful egg retrieval prior to the transplant. And she was awaiting the infusion of the engineered stem cells. And in July 2024, her gene-edited CD34 stem cells were infused with the busulfan myeloablative regimen. And she has relatively done well post-infusion as expected. Complications were fever, severe mucositis, pancytopenia, constipation, and DVT of the left lower extremity, which quickly resolved, associated with some nausea and vomiting. Prophylaxis for veno-occlusive disease and seizures was in place, but she did not have any related complications. Neutrophil engraftment was about day plus 20, and platelet engraftment was day plus 18. And after initial treatment of thrombus as above, with Lovenox therapeutic doses and its resolution, she was swiftly switched back to her home dose of long-term anticoagulation. So she was discharged from the facility on day 33. And since discharge, she has continued to recover very well, with the hemoglobin being at more than 10 grams per deciliter since after engraftment, and it continued to get better, and it was consistently more than 12 grams per deciliter since after day 39. And 100% performance on weekly evaluations to biweekly evaluations, and remains on infection prophylactic medications per their protocol. And most recently, the numbers that I have access to, her hemoglobin F was 33.3%, and hemoglobin A was 32.5%, and hemoglobin S 32.8%. And this was 2 months post-transplant. And she is actually currently 6 months post-transplant exactly today. And she's being evaluated for a 6-month bone marrow exam today. So I think I see that as a patient with a lifelong complicated sickle cell disease course with, her brief lifespan of, 11 to 12 years, where she did not have any respite until we started her on exchange transfusions to manage chronic pain. And without a matched donor availability, and her evaluation on the gene therapy clinical trial worked in a very timely fashion around when the gene therapy was indeed approved by FDA. And she successfully underwent the gene therapy and has done well so far. I mean, 6 months post-infusion, doing very well without any interim events or complaints at all. So we all know that the two available potential curable therapies are hematopoietic stem cell transplant and autologous stem cell infusions with after ex vivo genetic modification. And this could be either gene addition or gene editing. With gene therapy, with the potential to overcome many of the limitations that we all see with sickle cell disease patients is a lack of suitable donors, graft versus host disease, and the need for immune suppression and potential for graft rejection. But since the knowledge of gene therapy from the 1980s, there's been a significant progress. One with the supportive care, the technique of the gene editing and the gene editing addition methods that have really been improvised and improved with decades passing. And it's now to the point where we have these techniques available and approved by FDA. But more to realize based on the small numbers that have actually gone through the gene therapy. But results are promising nevertheless. And the current efforts are now are focused more on improving the efficacy and the durability of the response achieved with the curative treatments. So I was only going to focus on gene editing techniques as our patient did have the ex vivo gene editing and not the vector associated gene addition. The gene editing can be seen or can be done in a few different ways because the goal is for you to improve the non-sickle hemoglobin. That can be achieved via gene knockdown of the regulators of the fetal hemoglobin and gene editing of the globin regulatory elements to bypass and form non-sickle containing non-sickle beta globin chain containing hemoglobin, and using targeted nucleases such as zinc finger nuclease or CRISPR technique. Advantages of our gene addition, we just from the literature, we see this as the editing technique would significantly reduce or entirely avoid non-specific integration into the genetic material that could lead to insertional oncogenesis. However, with editing, there is a risk of off-target editing or deleterious on-target editing and consequences of double-stranded breaks that's still there. Most gene editing clinical trials for sickle cell disease have sought to increase the endogenous hemoglobin F expression through the knockdown of the BCL11A, either targeting the BCL11A erythroid enhancer on the chromosome 2 or targeting the hemoglobin F repressor binding sites on chromosome 11. So it's a sort of a stretched picture from the ASH publication in 2021. Just wanted to focus on the gene editing here, where the ex vivo editing happens with a non-viral vector or a viral vector, but in this case, it was the non-viral vector editing with the CRISPR, where you intend to deliver the double-stranded breaks into the regions via electroporation techniques, and based on the technique used with the homology-directed region, you are either upregulating the production of the non-S containing hemoglobin, or you are disrupting the pathway for the BCL11 pathway, resulting in hemoglobin F. So again, our future with gene therapy is looking bright, but more to realize and more data to come in to really, keep improving or adding to the data based on the improvement of quality of life and how meaningful improvement there is for that particular individual, because it's not going to be a blanket type improvement for all. And again, depends on the age they go into the gene therapy and their previous morbidity that they already have. Because we are promising a curative therapy, but the damage that is done already cannot be undone. So right now the data is trickling in, and there's going to be more to realize on the efficacy and the durability and the safety of the technique in the long run. But for the patient presented in this case, transplantation was not an option with not a matched donor availability. The gene editing technique for the intention to raise the hemoglobin F is a viable strategy for this particular patient. because her disease very visibly was only getting worse with age, with every passing day, actually. And so this patient went into the trial, provided there was a lot of time allowed for her to have the consultation, from the consultation to the stem cell collection, and to receive the product, the edited product. And there was a lot of thought and discussion between the team and the patient's family. And and I think the timeline was very interesting, even though it looked like a long drawn, but that time really allows you to make that informed choice to proceed with gene therapy. Now, I just wanted to ask the group about their individual experiences at their centers and how their patient population is doing. And if you guys have had children going to these gene therapy clinical trials before the FDA approval. And I would be interested to know how they're doing, and any personal experiences with the gene editing technique versus gene addition technique, and have they done any differently post transplant? And how strict are the inclusion criteria? Even though it's not a long laundry list of inclusion criteria, sometimes it may not be feasible to keep the hemoglobin S less than 30%. And in our case, I think we just proved to be lucky with the timeline. And I guess, the big question about the cost effectiveness and the finances is always going to be looming. So I just wanted to pause there and see if the group has any questions.
Thank you. I had a question, actually, not about the gene therapy, but I was surprised, and you may not have been at USA at the time, but I was surprised to hear that the team decided to wait so long before starting exchanges. We would start exchanges as soon as someone has had more than 2 recurrent acute chests. I didn't know if you had any information about that.
No, I think no, honestly, I don't know, and I don't know for sure, and I can't remember if we had those conversations and there was some hesitancy, if there was like a provider bias or a patient hesitancy there. But Dr. Imran, do you know? Or Dr. Pekmabian, if you're on the line, do you know if we've had conversations about starting her on exchange transfusions earlier on?
Dr. Mari,
Sorry.
it's been so long that I really can't remember in terms of conversations with the patient and her mom, that I really can't speak to that. I really just can't remember. We may have had that conversation due to the distance of traveling from Mississippi to Alabama. That is a barrier for a lot of our patients. That may have been an issue. I just can't remember. I just be honest with you.
Sure thing. And your point is well taken. And I think lately we have considered exchange transfusions or simple transfusions to exchange transfusions to help with the hemoglobin S percentage and the pain crisis. But, it is always viewed as a relative criteria in terms of the chronic pain management. So is a school of thought changing to have like a stricter criteria on exchange transfusions, like you mentioned, Dr. Cantor?
I mean, I don't think it's criteria based, and that's actually going to be a conversation this year in one of our discussions on at NASAC. But I mean, that's just what I have always done in recurrent, and I think the discussion on chronic pain is a different discussion than recurrent acute chest syndrome, which significantly increases the risk of long-term restrictive lung disease and mortality. And so for us, it's if you have 2 bad acute chest syndrome, certainly if you have ever been intubated, right away, I would have started someone on exchange transfusions.
Yes. I think your point is well taken. I don't know if there was really, I mean, there was probably not much of a gap in between one episode to another episode where she had to be in the hospital, and there was a simple to an exchange transfusion happening already to help with the acute chest. But I think that's a great thought and a point well taken.
Other questions?
Yeah, and I would love to hear experiences from other groups. because she is our youngest from our center. And honestly, we think she was just lucky and timing was perfect.
I will say, it is not curative therapy, and it's highly transformative. And the reason that we say that is that if you took her cells and put them in a mildly hypoxic chamber, you could make them sickle before somebody with sickle cell trait.
Mhm.
And so, I don't recommend the military. I still don't recommend people go scuba diving or decide to climb Mount Everest. In fact, I actually spoke to one of the individuals who went up Mount Everest recently who had gene therapy, or Kilimanjaro, whatever. But he actually told me he got jaundice about halfway up and needed oxygen. And he was fine. I mean, he was able to do it, but recognizing that if you make someone hypoxic, their cells can still sickle. So I think that's important, just as we counsel people long-term on continued long-term follow-up, because we just don't know what it will and won't fix, I think.
Mhm. Sure. Yeah, I think the long-term follow-up would be key in understanding, and I think also to improve the provider comfort and just informing them adequately in patients in how to take care of these patients after they are done with gene therapy. How do you follow them in the clinic, and like you said, what are the precautions they need to observe? Yeah. And
Others, I haven't taken care of any kids, so.
So is gene editing better than gene addition? Anybody has any thoughts?
We don't know yet.
Okay.
I think they're different.
Yeah. Excellent. Yes, and I just have my references slide to share, and that's all I have for today.
Awesome.
Yeah, thank you so much for this opportunity, and I'd love to. I mean, the gene therapy is something, the techniques are really beyond me. I have to review them multiple times, but I think this current clinical trial has done accruing and it's now approved, obviously. And I think there's a follow-up clinical trial that she's going to be, followed up on for 2 years at least. I think that was
15 years. So there's a requirement for a total of 15-year follow-up. So she'll
Okay.
be on, I'm sure, a long-term follow-up.
long-term. Yes. Yeah. All right. Thank you so much.
All right. Thank you for presenting, and thanks everyone for attending. And we will see you in 2 weeks.
Yes. See you. Thank you. Bye.